Okay, let's unpack this. Welcome, everyone, to the deep dive. This is where we take your source materials, could be notes, articles, research, and really boil them down to the absolute essentials. Today, we're tackling polycystic ovarian syndrome, PCOS. We've got a great set of revision notes here aimed at giving you that high-yield info you need, fast and effectively. Our mission. To walk you through these notes, we'll cover the definition, the causes, how it shows up, how it's diagnosed, managed, and, crucially, the long-term picture.
Absolutely. And using revision notes like this gives us a really solid structure. Sometimes just hearing it discussed helps connect the dots, especially with the complex things like hormonal disorders. We'll try to highlight those key links and takeaways as we go. Make sense of the science and the clinical side together.
Perfect. So let's start right at the top. The definition. What exactly is PCOS based on these notes?
Well, at its core, the notes describe it as a hormonal disorder. It's characterized by a combination of features. Often, yes, enlarged ovaries with multiple small cysts, but also, and this is key, significant hormonal imbalances and metabolic disturbances.
Okay, so despite the name polycystic, it's not just about cysts then.
That's a really critical point the notes make. While polycystic ovaries are, common on ultrasound, they're not always required for diagnosis. The underlying issue is actually deeper. It's a dysfunction in what's called the hypothalamic pituitary gonadal axis, basically, the control system between your brain and your ovaries. Understanding it's systemic, hormonal, metabolic, not just an ovarian thing. That's fundamental.
Got it. That's a really important distinction. How common are we talking here?
It affects roughly 10% of women.
Yeah.
And here's a stat that really hits home from the notes. It's listed as a leading cause of subfertility.
Wow, 10%. And a major factor in problems getting pregnant. That makes it super relevant for so many people. The notes also mention it's similar to metabolic syndrome.
Yes, and that similarity is, well, it's a big clue about the wider health impacts we'll get into later. The notes are also pretty clear. The exact triggers, what kicks it off, still unknown. It's a complex puzzle.
Okay, sticking with that mystery. Let's talk etiology, the causes. If the exact trigger is unknown, what do the notes suggest is going on?
Well, the notes explain that while there isn't one single cause pinned down, the current thinking is it's likely a mix, a combination of genetic predisposition and environmental factors coming together.
Not just one thing then, and what specific factors are thought to sort of contribute?
The notes list a few major players. Insulin resistance is a big one, various hormonal imbalances, of course, and elevated levels of androgens, male hormones. You can start to see how these pieces might interact.
Yeah, you can. Which leads us nicely into risk factors. If we don't know the exact cause, what makes someone more likely to develop PCOS?
So the notes highlight several key areas. Genetic definitely plays a part. If it runs in the family, your risk is higher. Obesity is a significant factor too. And insulin resistance itself. It's both, part of the condition and a risk factor for developing it.
And lifestyle choices, they factor in too, right?
Absolutely. A sedentary lifestyle, not much activity, and diet, particularly one high in refined carbs and unhealthy fats, are listed. Also, excessive androgen production is noted, which can, as we'll see with the pathophysiology, create a kind of feedback loop.
The notes touch on ethnicity as well.
Yes, they do mention a possible higher prevalence in women of South Asian and Black ethnicity, but importantly, they add a note. More research is needed there. It's not definitive yet.
Right. Now, let's think long term. Given that connection to metabolic stuff, what are the bigger health risks down the line for someone with PCOS? This really underlines why management is so important.
This is a really critical section in the notes. They list several serious conditions that women with PCOS have a higher risk of developing later on. Things like type 2 diabetes, obesity, which is both a risk factor and a consequence, remember, dyslipidemia, that's issues with cholesterol and fats, hypertension or high blood pressure, vascular disease, and even endometrial cancer. It's a stark reminder that PCOS goes way beyond just reproductive health.
That is quite a list. It really drives home the need for, getting diagnosed and managing it properly. Okay, let's get into the weeds a bit. Pathophysiology. How does this actually happen inside the body? How do these factors play out?
So the notes describe the core issue as a disruption in how the ovaries function and how hormones are regulated. The two central problems seem to be increased androgens and insulin resistance. They kind of work together in a negative cycle.
Okay, tell us more about that cycle. How does it work? Do they know what starts it?
Well, the notes explain that excess androgens, those male hormones, are produced by specific cells in the ovaries called the VUCA cells. Now, this production gets ramped up either because there's too much insulin floating around, that's hyperinsulinemia, due to insulin resistance, or because of elevated levels of LH, luteinizing hormone, coming from the pituitary gland. Then, the insulin resistance itself makes things worse. Not only does it directly tell the ovaries to make more androgens, but it also lowers the levels of something called sex hormone-binding globulin, or SHBG.
SHBG, what does that do normally?
Normally, SHBG binds to hormones like testosterone, keeping them inactive. So if you have less SHBG, you end up with more free, biologically active androgen circulating, which worsens the symptoms like acne or hair growth.
Ah, okay. So too much insulin and high LH both increase androgen production. And the insulin resistance also makes those androgens more potent by lowering SHBG. It really does sound like a cycle feeding itself.
Exactly. Multiple pathways reinforcing each other. The notes add that the high LH levels are because the pituitary is producing more of it. It's this whole complex interplay. LH, insulin, androgens messing with normal ovarian function. And while they mention the genetic link again, that specific gene, well, it's still elusive.
That clarifies the mechanism a lot. Now, since some PCOS symptoms could point to other things, what else do doctors need to think about? What's on the differential diagnosis list?
Yeah, ruling other things out is crucial. The notes list several conditions that can mimic parts of PCOS. Things like thyroid problems, hypothyroidism or hyperthyroidism,
Well,
hyperprolactinemia, which is high prolactin levels, Cushing syndrome, that's excess cortisol, a rarer condition called congenital adrenal hyperplasia, and importantly, hormone-producing tumors of the ovaries or adrenal glands. You have to exclude these.
got it. Let's talk numbers again, specifically prevalence. What does the epidemiology section add?
The notes make a useful distinction here. First, they talk about how common it is just to see polycystic ovaries on an ultrasound scan. That appearance might be seen in up to maybe 33% of women.
Okay, so just seeing that scan finding is relatively common, much more so than the actual syndrome?
Precisely. That's why the scan alone isn't enough. Then the notes give the prevalence for the full PCOS syndrome, with the actual features that's estimated to be between 5% and 15% of women of reproductive age. And they hammer home that point again. It is the leading cause of female infertility. That really sticks.
It definitely does. Okay, let's move to what PCOS actually looks like clinically. What does someone experience? What might a doctor find? The clinical presentation.
Right, the signs and symptoms. The notes cover a whole range. Often the first thing people notice is irregular or absent menstrual periods. That could mean periods are really infrequent, oligomenorrhea, or maybe very prolonged. Or they stop altogether, that's amenorrhea.
And what about the signs linked to those higher androgen levels we talked about?
That's the hyperandrogenism part. The notes list the classic signs. Hirsutism, that's excess hair growth in places like the face, chest, back out, acne pimples, breakouts, and male pattern hair loss, also called androgenic alopecia, thinning hair, typically at the temples or the crown.
And the polycystic ovaries on ultrasound, that fits here too.
Yes, seeing them on the scan is a clinical finding. It shows that increased number of small follicles, often around the edge. But, and the notes keep stressing this, it's not essential for the diagnosis.
And we mustn't forget the metabolic side of the presentation.
Absolutely not. Metabolic abnormalities are key. This includes the insulin resistance itself, which often shows up as obesity or difficulty losing weight, especially weight gain around the middle, that central obesity pattern. Dyslipidemia, abnormal cholesterol, or triglycerides is common. And that increased risk of type 2 diabetes reflected in potentially higher blood sugar levels.
The notes list some additional features too.
Right. Subfertility and infertility are explicitly mentioned here, with a sobering statistic present in about 75% of cases with irregular periods. The menstrual issues and obesity are repeated, noting obesity affects around half of women with PCOS.
And there's that skin sign linked to insulin resistance?
Yes, acanthosis nigricans. The notes describe it those dark, kind of velvety patches of skin, often in folds like the neck or armpits. It's a visible clue to significant insulin resistance.
Sure.
And importantly, the notes also list mood changes, things like mood swings, depression, anxiety, low self-esteem. These are really common and need attention.
When does PCOS typically start showing up?
The notes suggest the typical onset is around the peripubertal period, so around puberty through the mid-20s.
Okay. The notes also pull out some classical findings, things that connect the symptoms back to the underlying issues.
Yeah, they summarize. High LH levels, driving androgen production and contributing to the period problems. High estrogen levels, which can mess up follicle development. And that hyperinsulinemia, insulin resistance, boosting androgens, impairing ovarian function. Central obesity and acanthosis nigricans are common signs to look for. They also briefly mention rarer signs of really high androgens, like clitoromegaly or voice deepening, which might suggest something else, like a tumor.
That's a lot of potential signs and symptoms.
Yeah.
So how do doctors put it all together for a definitive diagnosis? This must be where the Rotterdam criteria come in.
Exactly. The Rotterdam criteria are basically the diagnostic checklist. The notes state you need 2 out of the following 3 criteria after you've ruled out those other conditions we mentioned. Criterion 1, infrequent periods or no periods at all. That's the oligo or anovulation. Criterion 2, signs of hyperandrogenism. This can be clinical, like the hirsutism or acne we talked about, or biochemical, meaning high androgens measured in blood tests. Criterion 3, polycystic ovaries seen on ultrasound.
And what counts as polycystic ovaries on that ultrasound? Any specifics?
Yes, the notes define it. Seeing 12 or more small peripheral follicles in at least one ovary, OR having an increased ovarian volume. So the key takeaway, the memory tip, 2 out of 3 needed periods, androgens, clinical or blood test, ovaries, ultrasound. That's the Rotterdam framework.
Excellent. A clear framework. So once PCOS is suspected based on symptoms and maybe meeting those criteria, what specific tests, what investigations are done?
Right, the investigations aim to confirm those Rotterdam criteria and check for related issues. Hormonal assessment via blood tests is fundamental. The notes list checking androgens like total testosterone, maybe DHEAS, also estrogen, progesterone, LH, and FSH to map out the hormonal picture. And crucially, they also test glucose and insulin levels to assess the metabolic side.
And the ultrasound's role.
A transvaginal ultrasound is the standard imaging mentioned. It's used to look closely at the ovaries, their size, their appearance, specifically looking for those multiple small follicles described in the criteria.
Are there other specific blood tests mentioned in the additional investigations?
Yes. Total testosterone, usually normal or just slightly up in PCOS. If it's very high, that needs more looking into. Free testosterone might be checked if total is high, say over 5 mmol, again to rule out other causes. SHBG levels, often normal or low because of the insulin resistance. The LH-FSH ratio is mentioned, sometimes it's elevated. The notes specify a ratio of 3.1 can be suggestive, though it's not seen in every single case. And then other blood tests might be needed depending on what other conditions need ruling out from that differential list.
What about checking for the metabolic problems directly?
Yes, glucose testing is routine. An oral glucose tolerance test might be done to get a better look at insulin resistance or prediabetes. And assessing cardiovascular risk factors is part of it too, checking lipid levels like cholesterol and triglycerides, tying back to those long-term concerns.
Okay, so the diagnosis is made. Now, the really practical question, how is PCOS managed? What are the strategies outlined in these notes?
Management focuses on 2 main things, according to the notes. Controlling the symptoms someone is experiencing and reducing those long-term health risks. And the notes are really strong on this. Lifestyle modifications are the absolute foundation, the first step.
What specific lifestyle changes are we talking about?
Weight loss, if overweight, regular exercise,
Yes.
and adopting a healthy diet. The notes explicitly say these steps alone can often normalize symptoms, sometimes without needing any medication. They also mention a low GI or glycemic index diet might be particularly helpful for improving insulin sensitivity. So lifestyle is really powerful here.
Lifestyle first, always. What about when medication is needed for specific issues?
That comes under symptomatic management. The combined oral contraceptive pill is very common. It helps regulate periods and can improve acne and hirsutism by managing hormone levels. Anti-androgen medications, like spironolactone, are options specifically for troublesome hair growth or severe acne. Metformin, the diabetes drug, is mentioned used with caution. It can improve insulin sensitivity and is sometimes part of fertility treatment too. Orlistat, a weight loss medication, might be used to help with weight and potentially improve testosterone and insulin levels. If there's high blood pressure, that's treated. But interestingly, the notes state no routine statin use. Just because someone has PCOS, you treat based on overall cardiovascular risk.
And fertility. That's
Yeah.
often a huge concern. What do the notes say about managing infertility in PCOS?
Yes, a key section. The main approach is ovulation induction, helping the ovaries release an egg. Clomiphene citrate, an oral medication, is listed as the first-line choice. IVF is an option for more complex situations or if clomiphene doesn't work. The notes add some detail. Consider clomiphene or metformin after trying weight loss, as even modest weight loss can sometimes restart ovulation naturally. Clomiphene is often preferred if obese and usually monitored with ultrasound scans. Metformin might be added to clomiphene or used alone. Injectable hormones, gonadotropins, are second line. Ovarian drilling, a surgical procedure, gets a mention as something that might temporarily help fertility, but it seems less common now.
The notes also had some general points on management.
Yes, really important ones. Patient education is vital. Making sure women understand the increased risks, cardiovascular, sleep apnea is crucial. And constantly reinforcing the importance of weight control and exercise, empowering people to take an active role in managing their own condition long term.
Okay. Given it's a chronic condition, what's the overall outlook? What does the prognosis section say?
The notes are quite clear. PCOS is chronic. There's no cure. But symptoms can be effectively managed with the right approach. They state that with proper management, most women can control their symptoms and live a healthy life.
But there's still that increased risk of complications we keep mentioning.
Exactly. That's the crucial caveat. The higher risk of type 2 diabetes, cardiovascular disease, and endometrial cancer doesn't go away. So, the notes stress that regular monitoring and preventative health measures are absolutely vital for long-term well-being.
Let's just quickly run through those key complications again, maybe linking them back to why they happen according to the notes.
Sure. Infertility is listed again common due to the lack of regular ovulation, endometrial hyperplasia, and cancer. This risk is significant. The notes explain why. It's because of unopposed estrogen. Without regular ovulation, the uterine lining is constantly stimulated by estrogen but doesn't get the progesterone signal to shed properly. This can lead to overgrowth, hyperplasia, and increased cancer risk. The management point here is using progestogens periodically to induce a bleed and clear the lining, reducing that risk.
And the cardiovascular risk.
The notes state explicitly, increased cardiovascular risk. This is linked back to those associated metabolic issues, obesity, high androgens, insulin resistance. They even mention potential issues with blood vessel function, compromised endothelial function.
Type 2 diabetes risk, too.
Yes, a significant increased risk. And importantly, the notes highlight this risk exists even in women with PCOS who aren't overweight. That's why screening is recommended. Sleep apnea is another one. Doctors should ask about symptoms like snoring or excessive daytime sleepiness.
And lastly, issues during pregnancy.
Yes, the notes list specific higher risks for pregnant women with PCOS, gestational diabetes, giving birth prematurely, preterm birth, and developing preeclampsia.
So the complications really do span across reproductive, metabolic, cardiovascular health, even sleep and pregnancy. It really shows it's a whole body condition.
Absolutely. The notes wrap up complications by listing the metabolic disorders again. Type 2 diabetes, dyslipidemia, metabolic syndrome, and reiterating that endometrial cancer risk. The take-home message is clear. Proactive management and regular checkups are essential.
We have covered a lot of ground there, really following the structure of these revision notes. From the definition, causes, symptoms, diagnosis, management, right through to the long-term picture. Having it laid out like this, I agree, makes a complex topic feel much more approachable.
It really does. It builds that solid framework for revision, helps you see how all the different pieces fit together.
Okay, before we finish, here's something for you, the listener, to maybe mull over. We talked about how the exact cause, the initial trigger for PCOS, is still unknown, despite understanding so much about the contributing factors and the mechanisms. What does that mystery imply about these complex hormonal and metabolic systems? Does it suggest that, for now at least, management will always focus more on symptoms and managing risks rather than a single cure? And how does that underlying uncertainty affect how doctors approach diagnosis and treatment, given how differently PCOS can present from person to person?
That's a great point to reflect on. It really speaks to the complexity we're dealing with and maybe the need for very individualized approaches to care.
Indeed. Well, we really hope this deep dive using these high-yield revision notes as our guide has been a helpful way for you to get a solid understanding of polycystic ovarian syndrome quickly and memorably.
Having that clear structure, that path through the information like we followed today is definitely key for getting to grips with complex topics like PCOS.
And if you happen to be revising for the MSRA exam and found this useful, you might want to check out passthemsra.com. They have comprehensive, high-yield revision resources.
Plus, for more free MSRA revision materials, you can also visit freemsra.com.
Thanks so much for joining us for this deep dive. We hope you'll join us again soon for another one.